Let's go over the warm-up review. First question, which areas of the hypothalamus regulate the autonomic nervous system? So the anterior hypothalamus controls the parasympathetic nervous system, and the posterior hypothalamus controls the sympathetic nervous system. And the last question, an investigative test uses a lab marker SCSQ to identify early small and squamous cell lung cancers. In a population of 100 smokers, 20 test positive. Of the 20 who test positive, 5 actually have either of the 2 lung cancers. So of those who do not test positive, it's determined that 5 have either of the 2 cancers. So what are the sensitivity, specificity, positive predictive value, and negative predictive value of this study? So here's how you're going to set up this problem. A is 5, B is 15, C is 5, and D is 75. So for sensitivity, you plug your numbers into the equation A over A plus C, and you get 0.5. For specificity, the equation is D over D plus B, and you get 0.83. For positive predictive value, the equation is A over A plus B, and you get 0.25. And finally, for negative predictive value, the equation is D over C plus D, and you get 0.94. Now let's move on to the lecture.
Hey guys, Dr. Carmichal here, and welcome to our Step 1 video on the other antibiotics. Once again, we have a group of antibiotics that don't really fit nicely into one or two categories. The common thread on the first drugs is that they can treat UTIs, but later we'll look at drugs like metronidazole and the polymyxins, and then close to the end we'll cover some specific situations where antibiotic prophylaxis is needed. The most commonly used sulfonamides are sulfamethoxazole, or SMX, which is easily the most commonly used, and sulfadiazine. Let's go over the mechanism of action of sulfonamides. Simply put, they are folic acid inhibitors. So that's how I like to think about this. Bacteria have no way of absorbing the folic acid from the environment, so they have to produce it internally. We humans can actually absorb folic acid from the environment. That's why we have pregnant women take a bunch of folic acid, because they can use it. The goal of these antibiotics is to prevent the production of folic acid in these bacteria and therefore deprive them of a vital component of their cell synthesis. Sulfonamides are competitive inhibitors of the enzyme dihydropteroate synthetase, which is a critical enzyme in folate synthesis. Sulfonamides can cover some gram-positives and gram-negatives. It can cover nocardia, chlamydia, and is used frequently for UTIs. Other clinical uses include skin infections as well. Most of the time, sulfonamides are used in combination with trimethoprim. By far, the most common combination is sulfamethoxazole combined with trimethoprim, TMP-SMX. The toxicities of the sulfonamides most commonly is a hypersensitivity reaction. There are quite a few people in the world with sulfa allergies. Hemolysis, especially if the patient is G6PD deficient. Nephrotoxicity, you can get some with tubular interstitial nephritis. Kernicterus can occur in infants, so you don't want to give this medication to infants or mothers who are about to deliver. It can displace other drugs from albumin, especially warfarin. You can get Stevens-Johnson syndrome, and you can get some photosensitivity. For resistance, you can get altered enzymes, so the bacterial dihydropteroate synthetase can be altered. You can get decreased uptake. You can get increased PABA synthesis. So, I mentioned before that many people have a sulfa allergy, but this doesn't just include sulfonamides. There are other drugs that are considered sulfa drugs, and we have a mnemonic to help us remember them. The mnemonic is, sulfa pills frequently cause terrible allergy symptoms. Sulfasalazine, probenecid, furosemide, celecoxib, thiazides, and TMP-SMX, acetazolamide, and sulfonylureas. In that list of reactions seen with sulfonamides, we also mentioned Stevens-Johnson syndrome. Let's review that one again. What drugs cause Stevens-Johnson syndrome? The mnemonic is, Steve Jobs made Apple PCs. Steve Jobs is supposed to make you think Steven Johnson, and then Apple PC will stand for allopurinol, phenytoin, phenobarbital, lamotrigine, ethosuximide, penicillin, carbamazepine, and sulfonamides. We just mentioned that we often use trimethoprim in combination with our sulfa drugs. So what is the mechanism of trimethoprim? It inhibits bacterial dihydrofolate reductase, so it's further down in the pathway of folic acid synthesis. The sulfonamides are inhibiting it at an earlier step. Remember, the sulfonamides are inhibiting dihydropteroate synthetase, and trimethoprim is inhibiting dihydrofolate reductase. So when we like to use the TMP SMX, we are hitting folate synthesis at two different locations. You almost never see trimethoprim used alone. There's another medication that inhibits dihydrofolate reductase. That's going to be methotrexate, and we use that a lot for rheumatological disorders. What are the clinical uses of trimethoprim sulfamethoxazole? It causes sequential block of folate synthesis, so you can use it for UTIs, Shigella infections, Salmonella infections, and sometimes we use it in MRSA skin infections. Patients who have frequent recurring UTIs may take TMP SMX regularly to prevent UTIs. In our AIDS patients, we use this prophylactically and as treatment for pneumocystis jirovecii pneumonia. When do we start using this as a prophylactic medication? It's when the CD4 count gets below 200. The toxicity in trimethoprim can lead to diseases where you get deficiency in folic acid, so megaloblastic anemia, leukopenia, and granulocytopenia. But the nice thing is you can reverse this just by taking a folic acid supplement. Another commonly used antibiotic in UTIs is nitrofurantoin. It's bactericidal in urine. Nitrofurantoin is reduced by bacterial proteins to a reactive intermediate that inactivates bacterial ribosomes. It has to be in the presence of bacteria in order for it to become effective. This medication is really only used to treat UTIs and generally mild UTIs. You don't want to use this for pyelonephritis or suspected pyelonephritis, and it's usually only good for treating bacteria like E. coli or Staph saprophyticus. Now that's great because those are very commonly found in UTIs, but it does not cover Proteus, which is another very common UTI-causing bacteria. The toxicity of nitrofurantoin is rare, but you can have nausea, headaches, or diarrhea. Another reason to use this medication is that it is safe in pregnancy. We're going to move on to the fluoroquinolones. Levofloxacin, ciprofloxacin, norfloxacin, ofloxacin, moxifloxacin, gatafloxacin, and nalidixic acid. Though it is not overly important, nalidixic acid is actually just a plain quinolone, not a fluoroquinolone. The mechanism of action of fluoroquinolones is that they inhibit DNA gyrase. It's important to know that that's topoisomerase 2. Remember, topoisomerase 2 is sort of the janitor of DNA. It does some of the nicking and removing. It doesn't actually change your DNA sequence per se, or what's actually coded. It just may help tidy things up. You don't want to take these with antacids or supplements that include calcium, iron, or magnesium, as it can inhibit the absorption. So for clinical use, we're going to use these for gram-negative infections, gram-negative rods, urinary tract infections, and GI tract infections. Some of these medications can cover Pseudomonas. There are varying amounts of gram-positive coverage. The first generation of drugs that we don't use anymore didn't cover gram-positives as well, but the second and third and fourth generations have much better gram-positive coverage, especially against strep pneumonia. Levofloxacin, third generation, and moxifloxacin, fourth generation, are great for strep pneumonia infections and are often used for community-acquired pneumonias or sinusitis. The toxicity of these is they have some pretty unique ones. GI upset is very common for most antibiotics, but it is contraindicated in pregnancy and children because of damage to cartilage, especially articular cartilage. One way to remember is that fluoroquinolones are bad for cartilage and your bones. So just remember that articular cartilage can be damaged in children. You can also get tendinitis or even tendon rupture in adults. So be aware that if you have an adult on fluoroquinolones and their Achilles tendon starts hurting, you probably want to tell them 1, get off the medication, and 2, don't go for a long run. Fluoroquinolones can also prolong the QT interval. You can use fluoroquinolones in children in one situation, and that's going to be cystic fibrosis. So cystic fibrosis patients get a lot of lung infections, especially Pseudomonas infections. So you can use medications like ciprofloxacin on a long-term basis, but you need to pay special attention to their cartilage and make sure they're not having any joint problems. The resistance to fluoroquinolones is chromosome-encoded mutation of DNA gyrase. So if the enzyme gets changed, you have less effectiveness. Okay, So that's going to finish off our UTI drugs. Let's cover some more antibiotics that don't necessarily fit into a larger category. Metronidazole is an antibiotic, but we also use it to treat protozoal infections. So how does it work? It gets absorbed by microorganisms and then it forms toxic free radicals that damage the DNA. And what specific organisms are we talking about? There's a great mnemonic that's been around for ages. It's get gap on the metro. Metro is metronidazole and get gap stands for Giardia lamblia, Entamoeba histolytica, Trichomonas, Gardnerella vaginalis, which is a bacteria, not a protozoa, anaerobic bacteria, which includes things like Clostridium species such as C. diff, C. perfringens, which causes gangrene, C. tetani, which causes tetanus, and also Bacteroides fragilis, so anaerobes think about Clostridium and Bacteroides. And then the P in gap is for pylori, H. pylori. Metronidazole is one part of the triple therapy or quadruple therapy that can treat H. pylori. It's not first line, but it can still be used. So that's the story for get gap on the metro. The first three are protozoal organisms and the last three are bacteria. Then, the other big thing to know about metronidazole is that it can cause a disulfiram-like reaction with alcohol. So what is a disulfiram-like reaction? We covered this in a couple places through the course because there are several drugs that might do this, but let's just review. Disulfiram is a drug that inhibits acetaldehyde dehydrogenase, so it prevents ethanol from becoming fully metabolized. When that happens, you get an accumulation of acetaldehyde, and that causes flushing, sweating, nausea, headache, and sometimes hypotension. And metronidazole can cause very much the same thing. So it's important to warn patients that this drug will cause that reaction before they start taking it. Tell them they shouldn't drink any alcohol while they are on the metronidazole, or it will make them very, very sick. Polymyxins act like cationic detergents. They attach to and disrupt bacterial cell membranes. They also inactivate endotoxin. For clinical uses, they are used for resistant gram-negative infections. For toxicity, they are neurotoxic and can cause acute renal tubular necrosis. And because of this, polymyxin are almost always used topically. So we see this used in many topical antibiotics like over-the-counter Neosporin. Briefly, we're going to talk about non-surgical antimicrobial prophylaxis. We talked about these a lot already. There are certain infections that if you get exposed to them or you have the potential to be exposed to them, you can take a prophylactic antibiotic. First, if you're exposed to a patient with meningococcal meningitis, ciprofloxacin is going to be your drug of choice, but you can also use rifampin or ceftriaxone. What about H. influenzae meningitis? Do we use Cipro there? No, we use rifampin instead. What if you want to prophylax for gonorrhea? When would you want to prophylax for gonorrhea? This might occur when the patient has been sexually assaulted and you want to ensure that they do not acquire gonorrhea, so ceftriaxone is what we use here. Syphilis prophylaxis, benzathine penicillin G. History of recurrent UTIs, so here you actually have a lot of options. You can use the trimethoprim sulfamethoxazole for long term. You can use nitrofurantoin long term. You can also use amoxicillin long term or cephalexin. Prophylaxis for pneumocystis jirovecii. This causes pneumonia in AIDS patients. So for prophylaxis, we use TMP-SMX most of the time. When do we start prophylacting for pneumocystis jirovecii pneumonia in an AIDS patient? When the CD4 count falls below 200. And what happens if the patient is sulfa allergic and can't take the TMP-SMX? So you actually have two other options. First, you can use aerosolized pentamidine. The other option is dapsone. So there are three prophylactic options here: TMP-SMX, pentamidine, or dapsone. Next, patients with mechanical heart valves or damaged endothelium of the heart can acquire endocarditis by having bacteria entering the bloodstream through dental procedures. They can take penicillin, or they can take one of the aminopenicillins like amoxicillin, or they can take cephalexin, which is the first generation cephalosporin. If there is a penicillin allergy, then you would use clindamycin or maybe azithromycin. And what was one of the major bacteria implicated with these? Viridans strep. Pregnant women with GBS. Remember, this doesn't adversely affect the mother, but it can lead to problems in the newborn, so we use ampicillin during labor to prevent transmission to baby. prevention of gonococcal or chlamydial conjunctivitis in the newborn, we use erythromycin ointment in the eyes of all newborns. There are a list of antibiotics you should not use in pregnancy, and these are potentially high yield for STEP, and some of them we are learning about today, but others we need to review as well. Clarithromycin is embryotoxic. Sulfonamides cause kernicterus, and only if taken close to delivery. Aminoglycosides cause ototoxicity. Fluoroquinolones can cause cartilage damage. Metronidazole causes mutagenesis only in the first trimester. Tetracyclines cause discolored teeth and inhibit bone growth. Ribavirin is teratogenic. Griseofulvin is teratogenic, and chloramphenicol causes a gray baby. Which is used for prophylaxis for the following infections? Gonorrhea is ceftriaxone. Syphilis is penicillin G. Recurrent UTIs can be TMP-SMX, nitrofurantoin, or cephalexin. Pneumocystis jirovecii pneumonia, or PCP, is TMP-SMX. Exposure to H-flu type B meningitis is rifampin. Endocarditis prevention in a patient with a mechanical heart valve. Remember that there are very specific criteria for who really need antibiotic prophylaxis for the endocarditis, but if indicated, we usually use amoxicillin, ampicillin, and if the patient is allergic to penicillin, we would use clindamycin or azithromycin. What are the major side effects of IV polymyxins? Neurotoxicity and nephrotoxicity. When should trimethoprim sulfamethoxazole be started for prophylaxis against pneumocystis jirovecii patients with HIV? That's when the CD4 count falls below 200. What is the mechanism of action of the following antibiotics? Sulfamethoxazole inhibits dihydropteroate synthetase. Trimethoprim inhibits dihydrofolate reductase. Levofloxacin inhibits DNA gyrase or the topoisomerase II. Nitrofurantoin inhibits bacterial ribosomes. Metronidazole forms toxic free radicals that damage the DNA. And polymyxin B acts like cationic detergent, cationic like cations and anions. That's it for this, guys. We'll see you at the next one.